Okay, so you guys ready to talk about maneuvers? So this is really what trips people up a lot, and hopefully we can sort of break it down and kind of make it easier to understand. Well, the first thing is patient positioning. So if they tell you about a murmur that's best heard in the left lateral decubitous position, they're trying to get you to identify mitral stenosis. You should think about mitral stenosis. If they tell you that the murmur is best heard with the patient leaning forward, that's aortic regurg. Okay, so now for the maneuvers that people hate to think about, but we're going to make it easy. Okay, so all maneuvers are doing or attempting to do is to manipulate blood volume. Okay, that's all that was standing, squatting, Valsalva, all that stuff. The bottom line is it changes the amount of blood flowing across a lesion. And the main concept you have to understand is that most murmurs are going to increase in intensity with more blood flow across the lesion. Okay, it's sort of the garden hose analogy. So if I have a garden hose, okay, and I've got my thumb over the nozzle, partially blocking it, and I go and I turn up the faucet halfway, well, as the water is coming out of the garden hose, it's going to run into my thumb, it's going to create turbulence, and it's going to create a sound. So it's going to sound like tss. What would happen if I didn't move my thumb and George went and he turned up the faucet full blast? What's going to happen to the sound? It's going to get louder, right? The same is true in the heart. So as you have a fixed lesion, a murmur, that's creating a murmur, it's going to get louder if more blood flows across it. That's all it is. And then conversely, if you decrease the amount of blood flowing across a lesion, then it's going to decrease in intensity. There are two exceptions to this, and we'll get to those in a bit. Okay, so how do you manipulate blood volume across a lesion? There are three basic ways. Okay, so you can alter blood return to the right heart, you can alter blood return to the left side of the heart, and you can alter afterload. Okay, so let's talk about each one of these individually. So how do you alter blood return to the right side of the heart? Well, that's inspiration. So if you have the patient take a breath in, what happens is their intrathoracic volume increases, so pressure drops, and so as pressure drops, now more blood is going to go. It kind of creates a vacuum, and more blood is going to go towards the right side of the heart as a result. Now, a lot of people think, well, by definition, if you have more blood going to the right side of the heart, wouldn't you also get more blood going to the left side of the heart? And the answer is no. I mean, eventually, the answer is yes, eventually that's true, because what's on the right must go to the left. But in that moment when they're taking a breath in, what also happens is that because the pressure drops, the pulmonary vasculature dilates. And so you get pooling of blood within the pulmonary circuit. So the left side of the heart actually doesn't get an increase in blood flow at that moment. So it isolates the increase in blood flow to the right side of the heart, which is really critical. If you're listening to a murmur and it gets louder when the patient takes a breath in, that's called Carvalho sign, and that indicates that the murmur is coming from the right side of the heart. It's a really powerful sign and can help you identify right and left-sided lesions, the last kind of part of our framework. Any questions about that? Okay, so next we're going to talk about altering blood flow to the left side of the heart. Okay, so how do you increase blood volume to the left side of the heart? This is things like leg raise or going from a standing to a squatting position. That's going to mobilize all the blood that's in the lower extremities back to the heart. And of course, it's going to go from right to left. But inspiration is not part of this, so there's no pulmonary vasodilation or anything, so it will go to the left side of the heart. To decrease blood volume, you can go from a squatting to standing position, or you can have the patient Valsalva, which creates an increased intrathoracic pressure, so it prevents blood from flowing back to the heart. Those are the ways you do it. Now, all murmurs, as we talked about, will increase with increased blood volume, except for, these are the two exceptions, mitral valve prolapse and HOCM, hypertrophic obstructive cardiomyopathy. And then all murmurs will decrease with decreased blood volume except for the same two murmurs, or lesions, mitral valve prolapse and HOCM. Now, if you want to memorize that for the test, that's great. You'll do fine. But just like anything else in medicine, it's always better to understand kind of the idea or the mechanism behind it. So let's talk about HOCM first. So if you can all imagine, my right hand is the left ventricle, and my left hand is the septum. Okay, so here's the cavity, the LV cavity. Here's the aorta. So when the LV contracts, the blood's gonna flow this way into the aorta, and here's the valve up here. So this is actually not a valvular lesion, hokum, but it's commonly, they like to trip you up, and it's commonly tested. So we should definitely talk about it. But there's the outflow tract there. Okay, so if in somebody who has hypertrophic obstructive cardiomyopathy, they have septal thickening. Okay, so that compromises, that further narrows that LV outflow tract, and that's what creates turbulence and creates the murmur. So if you can imagine, I do something to increase, LV volume. Let's say I go from standing to squatting, and it increases LV volume. What just happened to the outflow tract? It got wider, it got bigger, exactly. So the murmur decreases in intensity. That's the reason why that happens. Now, mitral valve prolapse, it's a bit of a misconception that the murmur intensity increases or decreases with maneuvers for mitral valve prolapse. I almost hesitate to say that because I think the test writers are also probably going to be operating under this misconception. But really what it is it's the click and the murmur move in systole. So it either starts earlier or starts later in systole. And here's how that works. So imagine, again, my right hand is the LV, and imagine my left hand is the valve. So here are the valve leaflets. And what connects the valve leaflets to my fingers? What are my fingers representing that connects the valve leaflets to the LV? Chordae tendineae, exactly. And that's the problem in mitral valve prolapse. These become lax through, from myxomatous changes or from Marfan, connective tissue diseases or ischemia or something. And so these become lax and kind of parachute into the left atrium. Okay? So, and that allows blood to basically flow through it. It doesn't pull the valve down taut. So what do you think would happen if my LV volume increased? It's going to pull those chordae tendineae along with it, and it's going to pull the valve down shut. Okay, so no MR, no regurg. When I start to contract, it's going to take longer to reach that critical volume at which the chordae tendineae then become lax and parachute into the left atrium. Okay, so the murmur happens later in systole with increased blood volume. So you can think about it, they're going to say that the murmur decreases in intensity. It's really that it occurs later in systole. And the same is true, or the corollary is true. If I start off with a really small LV volume from having the patient Valsalva, well, now it doesn't take much to reach that critical volume at which the chordae tendineae become lax and parachute into the left atrium. Does that make sense? So the murmur is going to happen sooner in systole with lower blood volume. Okay? Any questions about that? That's a good point. I think that there are several of the chordae, so if one goes out, unless you have complete rupture of all of them, which I've never heard of, I suspect that the others will kind of compensate in a way. But that's a good question. It's a good question. Any other questions before we move on? Okay, so then the last sort of maneuver is manipulating afterload. So how do you increase afterload? Well, this is kind of the hand grip. So you have the patient make a fist with both of their hands and squeeze, or you can put blood pressure cuffs on both arms and blow them up, and that will increase afterload. And as you might imagine, if you increase afterload, that's going to increase the pressure in the aorta. So murmurs like aortic regurg, where it's reliant on a gradient from the aorta back to the LV. If all of a sudden that gradient increases because of an increase in aortic pressure, you're going to get more regurg and you're going to get more blood flow and a louder murmur. Does that make sense? And then mitral regurg, blood will go to the path of lesser resistance. So if you have the LV squeezing, blood can go either out the aorta like it's supposed to, or in somebody with mitral regurg, it can go backwards into the atrium. So if all of a sudden you increase the resistance through the aorta by increasing afterload, well, more blood is going to then go back into the left atrium. So mitral regurg gets louder. So those are the two that they commonly will associate with alterations in afterload. Okay, so if your test mentions, hand grip, think, the murmur gets louder with hand grip or with blood pressure cuffs, think aortic regurg or mitral regurg.